So, shall we start? The first talk is by Dr. Sinumol. She is a professor in ophthalmology, Government Medical College, Thrissur. She will be talking about wound construction.
A very good morning to one and all, and welcome to Thrissur and welcome to Drishti 2023. My topic is the sclerocorneal tunnel incision. Let me ask you one question, which is the most important step in SICS? Any PGs? Yes, no doubt. It is the three-planar self-sealing sclerocorneal tunnel incision. And thanks to Dr. Blumenthal and Dr. Ruit also, who converted this 10 mm through and through incision with so many sutures and so much of astigmatism to a very beautiful 6 mm self-sealing 3-planar sclerocorneal tunnel incision with a square geometry. So what we expect from tunnel is a smooth delivery of the nucleus, easy implantation of IOL, an airtight, watertight closure at the end of the surgery without any suture, without any astigmatism and correction of any existing astigmatism, and a crystal clear cornea next day. So how this is possible with this tunnel incision? That is because of this geometric shape which allows stretching during delivery of the nucleus, and it is self-sealing. And we put a larger internal incision for easy engagement of the nucleus, at the same time a shorter external incision for minimizing astigmatism. And you should know the rule of astigmatism. Astigmatism is directly proportional to the length of the incision. This is for the PGs. So I am telling astigmatism is directly proportional to the length of incision, and it is inversely proportional to the distance from the center of cornea. That means if you are putting an incision close to limbus, your astigmatism will be more. And you should know the concept of astigmatically neutral funnel. This is a funnel-shaped area with 3 mm width at the limbus, and if we are confining our incision to this area, our astigmatism will be minimal. So our goal is to construct a perfect 3-planar self-sealing, astigmatically neutral sclerocorneal tunnel. We will see how to do that. So to master any surgery, we need to divide the surgery into steps and each step into components, and we should master all those. So here I am dividing the sclerocorneal tunnel incision into 3 components, that is external scleral incision, sclerocorneal tunnel and the internal corneal incision. The first step is the external scleral incision. We can call it as scleral groove. So this is a half thickness scleral incision. So instruments you know, that is number 15 blade, or if you are rich you can use a diamond knife, or we can use the crescent itself, and we need a fixation forceps. We should put the incision 1.5 to 2 millimeter behind the limbus, either superiorly, temporally or supratemporally. Ideal is to put it in the steeper axis. And we usually put 6 mm incision to, if we are having rigid IOL. If you have foldable, you can put a smaller incision. And if you are dealing with a brown cataract, you need to put a larger incision. And depth, this is very important. We should put half scleral thickness, that is 0.3 mm. You should remember the thickness of sclera near the limbus, it is 0.6. So we should put half scleral thickness incision. And these are the different shapes. And I prefer either frown or tower or chevron incision. Beginners can use straight incision. That is for minimizing the astigmatism. This smile incision is having more astigmatism. Now, you can see the video, how to put an ideal external scleral incision. You first stabilize the eye at 2 o'clock. During stabilization, you catch and lift, okay? Catch and lift the globe. Draw the mirror image of the limbus for frown incision. You can redo, you do it with minimum pressure initially, and we can redo it through same path to make it more deeper. And an ideal scleral groove incision will look like slight gray in color, like this middle picture. So this is slightly gray in color, and there is slight uplift and separation of the groove edges. And we can just insinuate the cutting edge of the crescent blade under its edge. This is very important. If you are doing a deeper incision, it will look like a black because you are nearing the ciliary body, and if it is superficial, it will be just white. Okay? Now, what complication can occur? You can get a full thickness incision. If your pressure is too much, you will cut through the sclera and will reach the ciliary body. And if you are injuring ciliary body, you will have severe bleeding. You should remember, ciliary body is one of the most vascular region of our body. Okay, so here, if there is severe bleeding, you suture that site and shift to the temporal site. Now, the second step, I will say this is the most crucial component of this sclerocorneal tunnel incision. We have to tunnel through half thickness sclera into cornea. So this is our instrument. We must know our instrument. This is crescent blade. It has an angulation of 45 degree, and it has a heel and a cutting edge, and its bevel is up. Bevel up configuration helps to prevent premature entry. So here is the second step. Again, fix the globe. Keep the crescent blade parallel to the globe. Okay? Always the blade should be tangential. So when in the center of the tunnel, you can make it just parallel. Begin tunneling at the central portion and engage the sharp edge of the crescent blade under the edge of the scleral groove, and with a slight wiggling motion, you can note that motion of that blade, slight wiggling motion, and we can tunnel up to 2 millimeter into cornea. So once the middle portion is tunneled, it is easy to extend sideways. So here the movement changes. There is slight, gentle slicing motion sideways to extend tunnel laterally. Now, we have already said creation of a larger internal incision is important because that helps in easy engagement of the nucleus. So we have to create side pockets. So this is again another case. So this is creation of the side pockets. So again, here we are using that wiggling motion to create the side pockets. And always check your tunnel for any intervening tissue. Okay, so how will you know whether we are in the correct plane of the tunnel? We can just see the outline of the blade through the sclera. We can just see the outline of the blade. If blade is too much visible, that means your tunnel is superficial. And if there is bulging of the outer tunnel wall, like this, bulging of the outer tunnel wall over the blade, or dimpling of cornea like this, that means your tunnel is again superficial. If blade is not at all visible, your tunnel is deep and you are going to have a premature entry. So complications possible are premature entry. There will be sudden escape of aqueous and softening of globe, iris prolapse, and then buttonholing if your tunnel is very superficial. So in both conditions, you stop dissection, reassess whether we'll have to suture or not suture or shift to temporal site. Now next, before the third step of sclerocorneal tunnel incision, it is better to put side port incision using 15-degree side port blade, and always keep the sharp edge towards surgeon and long axis of blade in radial orientation with the center of the pupil, and the blade should go parallel to the iris plane. So the ideal site for making side port is 90 degree away from the center of main port, or at least 1 clock hour away from the lateral end of the tunnel. So we should not join the main port and side port. Okay? Now after side port, you can stain the capsule, put visco, do rexis, and after that fill anterior chamber adequately with visco. I said adequately, don't overfill the anterior chamber. If you are overfilling, you will get a V shape in the next step. Okay. So just adequately fill AC with the visco, And our third step of our tunnel incision is the internal incision. So instrument we use is keratome. And again, you should know your instrument well, and always check your instruments before you use it. Check the tip, whether it is curved. If it is curved, it will injure your tunnel. If it is blunt, you will go for DM detachment. So just check your instrument. And again, put visco into the already made tunnel. It's a blinded tunnel now. To open up that tunnel, put visco for the beginner, okay? And introduce keratome into tunnel by a sweeping motion. So then gently turn the blade. You can see it here. So again, fix the globe, and with a gentle sweeping motion, you introduce your keratome into the tunnel. When the tip reaches the end of the tunnel, slightly dip to see a circle in the Descemet's membrane, and then smoothly enter into anterior chamber, and extend your entry sideways with the sharp side edge of the blade, and you cut while going in. If you are cutting, when you are taking out the blade, your tunnel will be narrow sideways. So you cut while you go in. So always remember, everything about incision has to be carefully planned before surgery. That is your first step. If you are going wrong, you will have more trouble next steps. So always plan before surgery, depending on the hardness of the nucleus. If you are having a hard brown cataract, put a larger incision, no problem. Then depending on the condition of the endothelium, if endothelium is having low cell count, again go for a larger section. You can put a suture at the end of your surgery. Then depending on the axis of the astigmatism. Thank you. Thank you, KSOS and Dr. Lakshmi, for giving me this opportunity.
Are we having discussion later, or shall we have a little bit now?
Can we have the discussion later at the end of all the presentations?
Fine. Thank you, Dr. Sinumol. You are not only a brilliant surgeon, but a wonderful teacher. Thank you for that good talk. We'll have discussion later.